Welcome to this medicine masterclass on splenomegaly. Splenomegaly is an enlargement of the spleen. Patients may present with non-specific symptoms such as fatigue that may be from anemia due to sequestration of red blood cells, night sweats, a low-grade pyrexia, a feeling of abdominal fullness or early satiety, and a history of lymphoma, leukemia or myelofibrosis, or in the developing world, conditions such as malaria, Kala-Azar, or a family history of Gaucher's disease. Radiological splenomegaly is based on the size of the spleen determined on CT scanning. A normal spleen should be less than 11 centimeters. Moderate splenomegaly is where the largest dimension is between 11 and 20 centimeters, and severe splenomegaly is where the dimension is greater than 20 centimeters. There are some key phrases that we should be aware of. Hypersplenism is splenic sequestration of blood cells, including red cells and white cells and platelets, extensive enough to cause cytopenias. Hyposplenism refers to reduced splenic function. Asplenia is an absence of the spleen or absence of splenic function. An accessory spleen is a separate region of splenic tissue in the abdomen present in approximately 15% of individuals. Splenosis is seeding of the abdominal cavity with splenic cells, and that can occur during surgery or trauma. Let's take a case-based approach to splenomegaly. Mrs. Jones presenting with lethargy and night sweats. Let's discuss the findings that we would expect on examination. A patient with splenomegaly on inspection should appear comfortable and may have signs of generalized bruising and pallor. The signs of bruising or petechiae could occur due to platelet sequestration, and the pallor may be as a result of anemia. On palpation, the abdomen would be soft and non-tender. Now, the spleen is found in the left upper quadrant, so you may note a mass palpable in the left upper quadrant which moves diagonally towards the right iliac fossa on inspiration with a medial notch. The mass is not ballottable, and you would not be able to get above the mass, and you'd comment on how many finger breadths or centimeters the mass extends below the costal margin, so perhaps 2 to 3 centimeters. On percussion, over the spleen, you would expect dullness over the left upper quadrant, and on auscultation, bowel sounds will be present, and there may or may not be a splenic bruit. Bear in mind the features to distinguish a left kidney and a spleen. The spleen is not ballottable, the kidneys are blottable. There's a splenic notch, not with the kidneys. The movement is important. The spleen moves infradiagonally towards the right lower quadrant, whereas the left kidney moves inferiorly in a very minimal fashion. Percussing the spleen is dull. Percussing the left kidney is relatively resonant, not due to the intrinsic nature of the kidney itself, but due to the overlying bowel. The upper edge of the spleen is impalpable, whereas the upper edge of the left kidney is palpable. Putting all this together, we would say that Mrs. Jones is a Caucasian female who presents with tiredness. The patient was comfortable at rest, and I believe the patient has signs consistent with splenomegaly. On inspection, the patient appears comfortable with signs of generalized bruising and pallor. The abdomen was soft and non-tender. A mass was palpable in the left upper quadrant, which moves diagonally towards the right iliac fossa on inspiration and has a medial notch. The mass is not blottable, and I'm unable to get above the mass. The mass is dull to percuss and extends 3 centimeters below the costal margin. On auscultation, bowel sounds were present, and peripherally there was no signs of underlying conditions such as rheumatoid arthritis. Causes of splenomegaly can be considered as causes of massive splenomegaly, moderate or mild. Mild splenomegaly can be caused by viral infections such as infectious mononucleosis or sarcoidosis, moderate infections as a result of portal hypertension or lymphoproliferative disorders such as Hodgkin's or chronic lymphocytic leukemias, and massive splenomegaly as a result of myeloproliferative disorders, or in the developing world, conditions such as malaria or Kala-Azar, or genetic conditions such as Gaucher's disease. Another way to think about splenomegaly is to define by whether there's a congestion of the spleen, things that would increase the edema of the spleen, for example, cirrhosis or heart failure, or thrombosis of the portal or hepatic or splenic veins would result in increased backflow pressures causing congestion and splenomegaly. Infections, whether they are viral, bacterial, parasitic or fungal, can also cause splenomegaly. Viral infections such as Epstein-Barr virus causing infectious mononucleosis can cause splenomegaly. Bacterial infections such as Salmonella, Brucella, tuberculosis, parasitic infections such as malaria, schistosomiasis, toxoplasmosis and leishmaniasis can cause splenomegaly, as well as various fungi. Another way to think about causes is whether they're hematological or malignant. Acute and chronic hemolytic anemias, sickle cell disease, particularly in children, could cause splenomegaly, and then as a result of chronic autoinfarction of the spleen, in adult sickle cell patients, the spleen usually atrophies. Myeloproliferative disorders such as myelofibrosis, lymphoma, acute and chronic leukemias, multiple myeloma, essential thrombocytopenia, myelofibrosis can all result in splenomegaly as well as tumours. Inflammatory conditions such as rheumatoid arthritis can also cause splenomegaly, and this association is known as Felty syndrome. Infiltrative conditions such as amyloidosis, Gaucher's disease or Langerhans cell histiocytosis all can result in splenomegaly. So there's a number of etiologies, and this is a nice way of classifying them. Just a little bit more about the relationship of rheumatoid arthritis and splenomegaly. Felty syndrome is a triad of rheumatoid arthritis, leukopenia, and splenomegaly. The bone marrow appears hyperplastic, and these patients tend to have a poor prognosis as they are at a higher risk of developing recurrent gram-positive infections. Now, patients with enlarged spleens, particularly if they develop complications, may require a splenectomy. As a result, their blood film and picture will change. Post-splenectomy, patients will have Howell-Jolly bodies, siderocytes, and spare cells. These are classic hematological findings. They would also develop a number of complications. Their susceptibility to infections would increase because the spleen has a very major immunological role and protection role. As a result, they are at high risk of developing streptococcus pneumonia, Haemophilus infections, Neisseria meningitidis, and other encapsulated organisms, as well as malaria. As a result, post-splenectomy, patients should have regular vaccinations, including pneumococcal vaccine, as well as the Hib vaccine and the meningococcal group A and C vaccinations, have long-term, lifelong antibiotic prophylaxis, usually with phenoxymethylpenicillin in patients who are not penicillin allergic, and strong advice should be given for foreign travel, in particular anti-malarial chemoprophylaxis, and patients should use insect repellents and mosquito screens and nets. Other important things to consider is the etiology, and the treatment would be to treat the condition causing the splenomegaly, and that may require a multidisciplinary team approach involving the hematologists, the oncologists, or the gastroenterologists. So we've covered splenomegaly, how the patient would present, the key findings on examination, the causes, splenomegaly by size, distinguishing the spleen from the kidney, a note on Felty syndrome, and the post-splenectomy blood findings, as well as the complications and how to manage those complications. Thank you for attending this medicine masterclass.